Good afternoon. We're here at the American Academy of Ophthalmology meeting in Chicago, Illinois, and I'm pleased to have this afternoon Dr. Nate Radcliffe from New York, New York. Thanks a lot for being here today, Nate.
It's great to be here, Jonathan.
Nate, every time we talk on this program, it seems that there's some exciting new glaucoma technology to discuss, and today is no different. We're talking today about a treatment called micropulse. Can you explain for us what that is and how it's used?
Sure. So micropulse is it's a treatment, a laser delivery strategy brought to us by Iridex, where a continuous wave laser, which is the way most of our sort of argon-type lasers are delivered, is broken up, and instead of being delivered, say, over 500 milliseconds, is delivered for, let's say, 1/2 of 1 millisecond at a time, followed by a 1 millisecond rest. And we call that percentage of time that the laser is firing the duty cycle. And the concept of breaking the laser up is to get a biological effect from laser without getting a thermal effect from the laser, because we're trying to get away from tissue destruction, and this is a way of getting some laser delivery but without collateral damage, thermal spread, necrosis, all the things you don't want from a laser.
That's a really great point about how we're trying to avoid the thermal injury. Can you give us an example, Nate, of what type of patient population this may be useful in?
Sure. So the laser that I'm talking about here is a 810 nanometer laser. So this is what used to be considered the traditional diode laser for cyclophotocoagulation, delivered through a transscleral route. And with micropulse mode, we're delivering what we feel is a safer laser treatment, less of the side effects that we're seeing with traditional cyclophotocoagulation. So we're not seeing profound hypotony or significant inflammation, or even there are reports in the literature of ptysis with traditional therapy. This is something different. So it may have a different mechanism of action. We may be seeing uveoscleral outflow as one of the mechanisms, probably also some aqueous suppression as you get with the traditional diode. So it's a new therapy, and who can we use it on? Well, we can use it earlier in glaucoma. It covers for me the sort of moderate to severe spectrum. Mild glaucoma, I have used it in certain cases, but they're very carefully selected.
Nate, this sounds like a really interesting technology. Is it done in the operating suite, or can this be done in the office as well?
I currently use the laser in both the office and the ASC setting, and I'll give you an example of how it works in both. In my office in New York City, it's convenient for me to deliver in the office. I'll use a retrobulbar block, and I discuss with the patient the delivery of that and the risks of the block. And we apply the laser just right then and there. I also, up in my office in the Bronx, have a surgery center with an anesthesiologist who delivers retrobulbar blocks. And because we have that available, we'll have the laser done up there. And again, after the block is performed in either case, I perform the laser, which only takes a small amount of time. Each treatment is 50 seconds to the top half of the eye and 50 seconds to the bottom. And I can vary the power settings based on how much treatment I want to have. And I'll apply some topical steroid after.
Nate, that's a really important point about the logistics of performing the procedure. Can we shift gears for a moment and talk a little bit about outcomes? What has been some of your experience in terms of intraocular pressure reduction with this technology, either in terms of millimeters of mercury or percentage?
Sure. So I've performed this laser now in 200 eyes, and we have looked at some of our data. We presented it at the American Glaucoma Society and ASCRS. We can get 40% pressure reduction, which is along the lines of what you expect with glaucoma surgery. What we're not seeing is the complications we've seen with transscleral cyclophotocoagulation. Now, in my practice, I titrate the laser very carefully. And some of the things you use to titrate are, how high the pressure is coming in, whether the patient is on oral Diamox or not. If they have reduced visual acuity, you can be more liberal with the dose of laser. If the patient has a lot of pigment in the eye, we want to back off on our laser settings because pigment absorbs laser energy, and we're more likely to shift over to that thermal effect that we're trying to avoid. So in my practice, I've brought patients with pressures of 60 and 70 down to the mid-teens by very judiciously applying the laser, and that's one of the things that makes it really unique, because depending on what laser settings you choose. It can be a very mild treatment, perhaps something that can be done at the time of cataract surgery along with some sort of MIGS procedure, or something that can be done in patients who have failed many incisional glaucoma surgeries and who need profound intraocular pressure reduction.
Nate, I want to bounce off that last point that you just made. I'm curious, because many new glaucoma technologies that we're seeing now are targeted not just for the glaucoma specialist, but also for the comprehensive ophthalmologist. I'm curious, it sounds more like this technology may be in the realm, in the wheelhouse of the glaucoma specialist. Would you say that that's true?
Well, I think in some sense that's true, because the best predictor of who is going to perform a future procedure is who's performed it in the past. And this is coming off of the diode transscleral cyclophotocoagulation. That's how most people start. But once they have experience with the laser, they'll move it earlier and earlier in the spectrum until you get to really the type of treatments that comprehensive ophthalmologists would be delivering. Comprehensive ophthalmologists have many patients in their practice that are candidates for this laser. Think of some of these eyes that have had a high pressure, or maybe an eye that's controlled but doesn't see well and has a lot of drop-related side effects. It's a great treatment because it can relieve those drop-related side effects. You can end up with a happier eye. So I think the new adapters, the comprehensive ophthalmologists who are always looking for new techniques to try to address the unmet needs of their patients will adopt this, and that we'll see it being used in the hands of the comprehensive ophthalmologist.
Well, Nate, thank you so much for introducing this new technology to us, and we're very excited to see how it blossoms in the future. Thanks again.
Thank you for having me.